Choanal atresia is a congenital condition where the posterior nasal aperture failed to canalize. So let us discuss on choanal atresia. What is choanal atresia? What is the embryology? What is the pathogenesis? The types, clinical features, diagnostic modality, differential diagnosis and management options. So what is choana or the posterior nasal aperture? This is diagram of the lateral wall of nose and choana comes exactly here. That is, actually it is an opening between the anterior nasal space, anterior nasal aperture and the nasopharynx. Posterior nasal aperture or choana. So it is bounded superiorly by body of sphenoid, inferiorly by part of vomer, laterally by medial pterygoid plate and medially by inferior portion of the palatine bone. Okay, so that is the boundary, and in this condition was first described in 1755 by Johann Roederer, and this is more commonly seen in females than in male unilateral. And bilateral choanal atresia is an otolaryngological emergency because the neonates are obligate nasal breathers, and bilateral choanal atresia will present as acute respiratory distress where we need to manage it as an emergency and to keep the alternate airways. But in unilateral choanal atresia can present as nasal discharge, and this will manifest or will be diagnosed at the older age because the child can breathe through the other nose, which is normal. Okay, only one side there is choanal atresia and the other choana will be normal. So we will chance of missing it early, and the diagnosis will be in the older age. So regarding embryology, this part was dealt in detail in an earlier class. So this choana develops between 3rd and 7th week of embryonic life, and there is a vertical epithelial fold between the olfactory groove and the stomodium, and rupture of this membrane will lead to the formation of choana, and that is called the bucconasal membrane. If there is persistence of this bucconasal membrane, this is the first reason or most common cause of a choanal atresia, and also contributed by persistence of the buccopharyngeal membrane or incomplete resorption of the nasopharyngeal mesoderm or inappropriate or misdirected migration of the neural crest cells. All these can lead to formation of choanal atresia. And in the types, this can be bony or it can be membranous or the partly bony and partly membranous, and that is a mixed variety, and there is a commonest type where in practice around 70% of the choanal atresia are mixed type, partly bony and partly membranous. This can also be unilateral or it can be bilateral. As I already told, unilateral mostly or most of the cases diagnosed at an older age group, and bilateral is a neonatal emergency because the neonates are obligate nasal breathers. And also this can be associated with the syndromes. Okay, associated with syndrome like charge syndrome. That charge syndrome was earlier described in detail. Or this can be as a part of Treacher-Collins syndrome or Dijor syndrome, etc. Okay, commonly associated with charge or Treacher-Collins or Dijor syndrome. So these are the types. And what are the clinical features? Clinical features we can divide it into clinical features in a case of unilateral choanal atresia and those in the case of a bilateral choanal atresia. So the neonatal emergency happens in case of bilateral choanal atresia, not in unilateral. Okay, bilateral choanal atresia present as neonatal emergency because the neonates are obligate nasal breathers. So there will be paradoxical cyanosis. What is that? Because there will be acute respiratory obstruction and also cyanosis will be present, but that will be relieved during crying and returns on rest. At the time of crying, the air passage through the mouth will be open, so that will be cyanosis will be relieved. So that is called paradoxical cyanosis. That is cyanosis relieved by crying and returns on rest. and difficulty in feeding, and this can be to an extent the feeding can be made more comfortable using MERN, MERN, MERN nipples. Okay. And there will be apnea, and also there will be failure to thrive. But in a case of unilateral coronal atresia, will present as usually presenting as a unilateral nasal block or nasal obstruction, and there will be persistent mucopurulent nasal discharge which is not relieved by medical treatment. Okay, medicines and nasal discharge. Persistent mucopurulent nasal discharge not relieved by medicine. If a child presenting with nasal block and nasal discharge not relieved by medicine, the first thing you have to suspect is coronal atresia. So bilateral coronal atresia and unilateral coronal atresia. So if there is any level of clinical suspicion by the above clinical features, you can pass a nasogastric tube or nasal suction catheter through the nose, and if it is not coming into the oral cavity, if there is a block, it will lead to the suspicion of an coronal atresia. So the diagnosis is mainly by clinical suspicion, and you can do mirror test or cold spatula test. Keep a cold spatula and look for the fogging. Also, that's also mirror test. Then endoscopy, that is diagnostic nasal endoscopy, is a gold standard in the diagnosis. You can actually see the presence of or absence of coronal atresia. Then imaging, mainly CT scan of nose and nasopharynx. You have to do an axial, then coronal, and also bone cuts, bone windows. That is to know the thickness, then anatomical relations, and also the type of coronal atresia, whether it is bony or membranous or mixed variety. Okay. And if you suspect any syndromes, if suspecting any syndrome, do a cardiac echo or renal ultrasound scan or ophthalmology or audiology evaluation depending upon the type of syndrome you are suspecting. So mainly the endoscopy is the gold standard, and also CT scan, mainly the axial, coronal and bone window cuts are the gold standard in the diagnosis of a coronal atresia. Then in the differential diagnosis, mainly the nasal dermoid encephalocele and deviated nasal septum and congenital pyriform aperture stenosis are the differential diagnosis of bilateral coronal atresia. And the nasal foreign body can present as a unilateral coronal atresia because the presence of foul-smelling nasal discharge, mucopurulent nasal discharge, which is not responding to medicines. Okay. And in the management, initial stabilization is most important, especially in cases of a bilateral coronal atresia. So surgery can be postponed up to an age of 6 months of age. But in cases of severe obstruction, initial intervention may be required. And you can keep the maintained airway is by either by an oral airway or by an endotracheal intubation or by using a MERN nipples, and always treat the associated anomalies like cardiac or respiratory, any anomaly, especially in case of syndromic association. And in the case of surgical management, surgery, the gold standard is the endoscopic transnasal approach. And there is also transpalatal, transeptal or transantral, but this transeptal and transantral is only an historical importance, and transpalatal we do in cases of revision surgery or in cases of severe craniofacial anomalies. So endoscopic transnasal approach is a gold standard in the treatment, and here we use 0 or 120 degree rigid endoscopes. If 0 degree endoscope, it is passed transnasally, and either serial dilatation using urethral sounds or the using powered instruments like microdrill. And if the nasal cavity is too narrow to accommodate the endoscope along with the instrument, we can make a window in the posterior part of septum and through one nostril the endoscope can be passed, and through the other nostril the instrument or the micro drill is passed. And if using 120°, the endoscope is placed through the oral cavity. It is placed in the nasopharynx behind the soft palate, so that the choanal area can be visualized, and then the instruments pass through the nose and the atretic part or the bony or membranous part is drilled out. Okay. So and after this, postoperative stenting and mitomycin C application in order to prevent restenosis or granulation tissue formation is under debate. So many evidence is against using mitomycin C, but so many meta-analyses are present showing the telling the importance and use of mitomycin C. So stenting along with mitomycin C is under debate. But anyway, you need a serial follow-up for at least for 2 to 3 years after surgery. So always consider choanal atresia in a child with a cyclic or paradoxical cyanosis, and CT scan of the nose and nasopharynx is the investigation of choice, and transnasal endoscopic surgery is the treatment of choice. And early identification and management of airway save life, and the surgery will give a long-term benefit. Okay.